My name is Kaz Mitchell. I'm the director of Circle of Voices, Inc. We're here to talk about health disparities. It's a time to heal, address health disparities. I'm not going to talk about who I am. It's all in the presentation and so forth in our distinguished panel. So I'd like to start, and I'm also going to be passing around a sign-in sheet, so if anybody wants to contact us or we could update you, we'd like to have your information, as well as a palm card so you can have our information. So thank you, and let's go. Yes, it's a time to heal. We're going to be addressing our health disparities. I'd like to introduce our panel right off the bat. Our executive director, Jean Wembley, could not make it this morning, but she's okay, but we had a little situation, so she sends her regards, but I would like to respectfully honor her by saying thank you, because if it wasn't for her, we wouldn't have Circle of Voices. Jean Wembley, executive director and founder, is a legend in the LGBT community. So I wanted to share a brief story that Jean stood up amongst close to 8,000 to 10,000 women at Mitchfest in 1979 to address the disparity of women. There was only approximately 25 women of color at the entire festival. There was a group called the Hearts that gave them a few minutes of their performance time. And Jean and her fellow sister, Umoja Three Rivers, read the list of grievances that they had concerning that great disparity. So that was the beginning of our work in addressing disparities amongst women of African descent and people of color communities. So by Jean doing that, the producers gave them a tent, and Jean organized that tent and asked women to come together and tell their stories and lock their hair and play their drums and do what was special to them while they were feeling so bad at this event. And it became the main staple in the Women of Color festival communities. And I'm just sad to say that this year was the last Mitch Fest after 40 years. But that is how Circle of Voices began as a Women of Color music festival. So to Jean Wembley, thank you. I'd like to welcome our panel of distinguished guests. First we have Rosina Nina Riley, LMSW. She is a licensed social worker with 20 years of experience working with diverse populations who provides creative and quality social services. Her areas of expertise are individual and group counseling, curriculum development, client advocacy, and community education. Our next distinguished guest is Lori Hannibal, LCSW-R. Lori is an accomplished administrator with a broad background in social services, both supervisory and clinically, and has extensive experience with programs for youth and families. At present, Ms. Hannibal is a regional director of the SCO Family Services Bridges to Health program in Dix Hills, New York. In addition to her administrative work, Lori has a thriving clinical practice providing counseling for adults, adolescents, couples, and the LGBT community. She influences and spiritually of women in her day-to-day lives through her women's ministry of her church, Long Island Community Fellowship, as the ministry lay coordinator. Our next distinguished guest is Shy Mitchell, RN, CM. Shy Mitchell is an RN case manager in oncology. She was employed at Mount Sinai as a professional nurse since December 2000. Currently retired and is now CEO of Litton Community Services and Litton Nurse Consultants, LLC. She has held various positions over the past 30 years, such as UR QA coordinator, home care case manager, public health nurse, admissions nurse, supervisor, and staff nurse. She was a commissioned officer in the United States Army Nurse Corps for 2 years, and in the reserves for 12 years, discharged as an officer of the United States Army. Yay. So that's our distinguished panel. Again, I'm Kaz Mitchell. I'm the current chair of Callan Lord Community Advisory Board. We are a advocate board to help with the operations on the client level at Callan Lord. So we make a major impact on services and things that they do, as well as my commitment to Circle of Voices. I'm also a journalist, and sometimes when I feel like it, I do a little comedy, because I got a lot to laugh about, because I have a lot to cry about too. So let's get to work, ladies. We're going to talk about health disparities. And in Circle of Voices, our current initiative is called A New Boo, About Us, Needs for Us, Because It's Us. And we do this work through workshops, support, and fun. Our mission is we are a nonprofit women of African descent and women of color organization that produce multicultural events of artistic nature and nourishment for the human spirit. We provide creative arts environment where all orientations can exchange information, histories, knowledge, and skills amongst each other and the community at large through performances, workshops, music, festivals, and seminars. And I stress women of African descent because, as you know, in our community, the history of this country has not been nice to people from African descent. So there's an urgency to make it clear and precise that they are welcome. So that is why, if you're wondering, we mention and separate that, because Black community members sometimes get lost in that people of color genre. Now, needs for us. So often the greatest impact in lesbian, bisexual, same-gender loving, trans, queer, questioning women's health is the tendency to avoid helping, and we try to help them to seek follow-up, returning to care, because we usually don't follow up once we get them into the hospitals. There's a lot of discrimination that we're impacted by in the LGBT communities. Sometimes the people that don't do our paperwork correctly, because some of us have different names. Some of us don't like our birth names, so records get screwed up, and some people do it on purpose. So we are working closely for cultural competent communities, and if I want to share with you that Liz Margulies and I had the great pleasure of testifying a few years back, and also Christina Modell, who you'll speak from later, at City Council around cultural competency issues, and Liz and her team offered training, culturally competent training, to New York's Health and Hospital staff. So just let you know that we see it and we know about it and we're working on it. So what we do, we try to make sure that people that are having difficulty finding screenings or preventative care, especially same-gender loving women, trans community with breasts, to make sure they know that they have free mammograms, because after age 40, that's when you need to start doing that, and it saves lives. So we offer opportunities for free mammograms, insurance for things like pap smears, because as you know, at age 40, certain diseases become prevalent, and a lot of times that is mental health issues, because they don't know that they have something else wrong with them. So these are some of the things that we offer with our 3CR cultural competent caring resources that we offer for women. So now we're going to talk about the topic of the day, health disparities. And we just listed some of the reasons that we're going to touch base on, from sexism to sexuality, racism to discrimination, economics, culture, homelessness, homophobia, genetics, diet, and intake. And some of the discussions that we're going to talk about are experimentation that causes a lot of the disparities, slavery and prison experimentation, history of biased care, alternative methods, ethics, lack of morality, cultural competency, disbelief, not necessary, isolation, indifference, and lack of directives such as our health proxies. Okay, so I'd like to share a little YouTube clip with you so we can get the conversation going and let you talk to the experts. So Here we go. Good luck. The clip is called Medical Apartheid. It's by Miss Harriet Washington. She studied disparities from slavery to now. I'm only going to show the first 5 minutes because it's an ongoing series of hours and hours, and some of it does get quite deep and maybe a little graphic, so I'm only going to play the intro. I understand if you want this information, it'll be on the website at the end of the program. If not, we'll be able to get it to you if you let us know. So I can't say enjoy because it's sad.
The American Cancer Society shows that African Americans are still more likely than any other group to develop and die of cancer. The study states that socioeconomic factors play the largest role in this disparity. African Americans have less access to health care and information and are less likely to get screening and medical treatment. Well, the new book offers one answer into why Black Americans deeply mistrust American medicine. Medical Apartheid, the dark history of medical experimentation on Black Americans from colonial times to the present, is the first and only comprehensive history of medical experimentation, abuse, and neglect of African Americans. The book reveals the hidden underbelly of scientific research and the roots of the African American health deficit. It begins with the earliest encounters of blacks in the medical establishment during slavery, looks at how eugenics and social Darwinism were used to justify medical experiments conducted by the government and the military, and offers new details about the infamous Tuskegee experiments that began in the 1930s.
Medical Apartheid also examines less well-known abuses and looks at unethical practices and mistreatment of African Americans. They're still taking place in the medical establishment today. We're joined now by the author of the book, Harriet Washington, a medical writer and editor, visiting scholar at DePaul University School of Law. We welcome you to Democracy Now!
Thank you. I'm very happy to be here.
Well, this is a fascinating book. First of all, why did you take it on?
I took it on for two reasons. One, I'm a very naturally curious person, and when I was still in pre-medical undergraduate at the University of Rochester, I was working in a hospital and came across some case files that dramatically showed a disparity, a racial disparity in people who were slated to receive kidneys. And that piqued my curiosity.
What do you mean?
Well, I came across some old case files in a forgotten file folder, and one was of a black gentleman, one was of a white gentleman. The white gentleman's file was thick and full of testaments to his loving family, his insurance support, his determination to live, and detailed really Herculean attempts on the part of medical personnel to procure a kidney for him. Kidney transportation still being relatively new then. The file of the black gentleman was very thin. The word Negro appeared on every page of it, and somebody had underlined it on his social profile right above the single line that indicated that the medical staff's plans for him were to help him to prepare for his imminent demise. The white gentleman and the black gentleman were very similar in their profiles, but they were treated differently. And I wanted to know whether this was a consistent feature of medical care or just an anomaly. And as I began looking into it, I just became intrigued in the vast differences in the way African Americans were used for research.
But your book doesn't just deal with modern times, but you go back into the beginning of the country and exactly how these kinds of disparities began to manifest themselves. Could you talk to us a little bit about, especially about those early years, especially during the period of slavery?
Right, the early years was quite chilling. First of all, it's important to understand that there was a scientific animus called scientific racism, which at that time was simply science. And it posited that black people were very, very different from whites, medically and biologically. And this provided a rationale and underpinning not only for the institution of slavery. Slavery probably could not have persisted if there hadn't been this medical underpinning, but also for the use of blacks in research. For example, it said that blacks were less intelligent, subhuman, perhaps not even quite human, that they didn't experience pain, that they were immune to diseases like malaria and heat sickness that made it impossible for whites to work in the field, but made them perfect for labor in the field. So this set of beliefs, a set of scientific beliefs, was not buttressed by any real data, but only by the needs of the community. And this actually gave permission for doctors to acquire slaves for research. They also had a variety of conditions for which a good example is reproductive health. All of the early important reproductive health advances were devised by perfecting experiments on black women. Why? Because white women could say no. White women were not interested in having doctors looking at their genitalia during the Victorian era, and white women were not interested in undergoing painful surgery without anesthesia, but black women could not say no. So this animus began, as you say, in the very early days of our republic, and it simply snowballed until by the time of the Civil War, blacks were being used almost exclusively in some venues and in very high proportion in others for everything. Vaccine design, experimental surgeries, and they were never consensual, you never asked their permission, and rarely were they therapeutic. They were mostly to expand medical knowledge.
We have to go to break. When we come back, I want to ask you about the Tuskegee.
So thank you so much. It goes on and on. She gives details about the true Tuskegee experiments and the things that went on. So I urge you to look into this Harriet Washington's medical apartheid. So I'd like everybody to come back, and Christina Modell, who's also one of our distinguished colleagues. We had the distinct pleasure of working together at the Lesbian Cancer Initiative. So Chris, could you come up? Because Chris is going to also share some valuable information around cancer and mental illness and how that goes together. So as professionals and talking to you, each one has a different expertise. So respectfully, I think the person who has the expertise should tell their expertise and possibly open up with a story that's relevant to some of the health disparities that they see in their work. So, Shai, you like to start? Thank you.
I started off at 27 years ago at Mount Sinai Hospital when they had offered home care to the community. And if you lived above 96th Street, you were not given home care. You did not get transportation. You did not get a nurse. You did not get a physical therapist. You did not get a home health aide. You did not get anything unless you came to the hospital. So once you got treated for whatever you needed at the hospital and sent home, you were left to fend for yourself with your family. The majority of times, those African Americans or LGBT patients end up coming back to the hospital because number one, they didn't know how to take their meds. Number two, they didn't know what symptoms to call their doctor for. They didn't know when to come to the emergency room. What was the symptoms that was needed to look for health care and look for a doctor? So I worked on a team, had only 4 black nurses, and we decided to petition and fight to take home care from Mount Sinai to up in Harlem. At that time, I was living in Harlem, so I felt really upset that I could not serve my own community. So we fought. We began to make changes. It took us 5 to 6 years to make a great change so that the community got the home care, because Mount Sinai is a great hospital. But if they have disparity for health, then that was a problem. And one of the examples I had that really upset me, this patient husband had a stroke, and the husband called out and was paying for home care. He was trying to take care of her, but the patient could not talk. So nobody could take care of this patient properly because the patient had wounds, she had a stroke, she couldn't be fed properly. I go into the house and there's disparity with language, but also disparity because they come out of a clinic. If you have Medicaid, you come out of a clinic, no one really pays you any attention. They don't even call to say, why you miss your appointment? Because none of them care. So I go into this household and found out that this patient cannot come out to clinic appointments, cannot have the care that she needs, and I end up having to call back to the hospital and have an ambulance take her back to the hospital. So my plan at that time with my supervisor was that if they cannot give her 24-hour help, then there was no need of her going back home. because either they have to put her in a nursing home or they have to give her 24-hour care. And that was a great battle to try to get this lady 24 hours because, one, she didn't have enough insurance. Her husband was still working. They weren't on the Medicaid. So his health care, Blue Cross or Blue Shield, whatever one they were, commercial, did not serve 24 hours. So we had to then ask the hospital to pay for the care until a social worker could come in and help them get Medicaid, maybe they call it spousal refusal. That means that the husband is not responsible for the care under his health care plan because it doesn't cover enough. And basically, this goes on through the whole community.
Any questions or anything for her? All right. My name is Nina, and my work is different from a lot of other social workers. I come from the thought that we are all spiritual beings having a human experience, so I like to bring the spiritual aspect into my work. Initially, when I started, that was forbidden. You know, it was frowned upon to even think about spiritual ways of addressing health and healing. And it took a while for that to come through. My involvement with the LGBTQ community started with my working with HIV and AIDS. And at the time, I was like one of the few social workers in the field, Black social workers in the field, and I got from a lot of people, it's like, wow, it's good for me to see you. It's good for you to be here because no one else is able to understand me properly. So it's really important that more people understand the power of their presence in working with our communities. When I did work with the HIV community, I worked in the clinical trials unit, and it was a very important piece because it was the first time that people of color were really put under the microscope in clinical trials in that way. It was usually white gay men that were the subjects of the trials, and so my initial entree into that was an important piece. And I learned a lot. I learned a lot from the clients, the patients, as well as from the administrators. And the main thing that I work with, I think, is more like energy medicine, you know, in ways to empower ourselves. So I'll pass that.
My experience is more from the child welfare perspective. So I've worked many years with children and parents who have come through the foster care system. And what I've noticed is the inequality that when you're working with parents that are underserved, they may or may not have mental health issues because that is not identified at the time, is that people tend to treat them differently. And quite honestly, it wasn't any difference between an African-American caseworker versus a white caseworker. They were still being treated as if they were less than. And one of the things that I tried to help my staff to understand is that obviously people needed to be treated the same, but you were put here for a purpose. And if you're put here for a purpose in terms of this environment, in terms of working with the family court system or working with different substance abuse programs or whatever, you need to be vigilant in terms of helping them and helping them to understand what they need to do differently, and that you need to learn from them. And I think that's the other thing, that sometimes people don't understand, or workers, whoever, they're not understanding that you're learning from your clients as well as your clients hopefully are learning from you. I also think that when it comes to the children, helping parents to understand that even if they're in a situation, there's something positive happening from that. You know, we always talk about evidence-based and strength-based. There's all the titles that you can use, but helping someone to understand that even at your lowest point, the fact that your children ended up in care is giving them an opportunity to do something different. It's giving you the time to do something different from yourself. And I think that, again, going back to the difficulty of people coming to receive services, whether it's mental health, whether it's physical health, I think it's also about them needing to know that first they need to be taking care of themselves.
Hi, I'm Christina Moldau. As Kaz said, I was program coordinator for many years at the Lesbian Cancer Initiative of the Lesbian, Gay, Bisexual, and Transgender Community Center here in New York City. And Kaz asked me to speak from my perspective and just kind of want to say a little bit about who I am and where I stand in relationship to my perspective, in part as the white person on the panel. I am someone who has gone through 2 cancer diagnoses and navigated the system as a white person of privilege who is an English speaker, who has residency in the US, and has a number of things that made a very, very difficult experience for anybody to navigate, less difficult than it is for many people. I also, in my role at the center, have worked with a number of really incredible women primarily, and cisgender and transgender identified people going through a cancer diagnosis, who clearly are people who connected with mental health services because I am a mental health provider and was working with them in that context. And among those women, most of them were people who had a skin color that was different than mine, and I also think of myself as an ally, and when I was thinking about that in the last couple of days, I was sort of thinking like, well, how do I define that? How do I think of that? What does that mean? And so I kind of wrote something up, and I'll just say that I've thought of that as being someone who attempts to understand as best as I can the lived experiences of those who are different than me, in particular in relation to systemic power and privilege, and to use to use that privilege and be an advocate for change wherever and whenever I can figure out to do so, and made me connect very much to what Dr. Ashley said this morning about having cultural humility and thinking of myself as sort of a lifelong student of that, in that I know so little about other people's experiences other than my own and what I've learned from connecting with and listening to other people. It's hard to pick a specific story of somebody who I've worked with, but there are 3 that come to mind. One, I'm not going to tell all 3 of them, but I'll just sort of say generally that one is of a young African-American butch-identified person with stage 4 breast cancer who I worked with as a couple. I worked with her and her partner. And another is a even younger, in her 30s, Latina woman dealing with both breast and uterine cancer. And a third is an older Black and Latina identified, also butch identified woman who I worked with through a breast cancer diagnosis, which was immediately followed by an esophageal cancer diagnosis. And all of them were and are dealing with advanced cancer, and all of them are still living. And, you know, in their very own ways that are deeply inspiring to me, are thriving. Even though they are still have big health challenges before them. And I want to say that I think that a key thing that, well, clearly all of them sought out mental health services, and I think probably for each one of them that I met with and got to know and have deep respect for, there are so many other people who are not connected with mental health services or medical services, and whose lives are at much greater risk for that. And when I think of these three people in particular, some things that they have in common are that, that they knew or came to know on some level that their lives matter. And, I just sort of think that the Black Lives Matter movement is so critically important and will have a systemic, certainly we hope will have a systemic impact on what we see going out there in the world, both in many, many people's lives and in impacting, structural racism. And whether that was mattering to a partner, one person was, the older woman was quite socially isolated, but was also a primary caregiver for her elderly mother who was in her late 90s. And that was a relationship that she drew a tremendous amount of strength from. And the younger African-American woman that I was working with, who figured out to get a second opinion, go to another medical system that she felt more comfortable with. She was initially working with doctors at a very prestigious New York hospital and did not feel well treated by them, and had the wherewithal to call up, the Cancer Centers of America after seeing the commercial on TV where, everyone looks so nice and the environment. And anyway, she got connected with Cancer Centers of America and worked it out with her Medicaid insurance to be able to fly out several times a year to Chicago for her treatment. And also figured out to support her partner through getting pregnant and having a child, which is something that they had a dream to do together, even though she did not know what her mortality was going to be and was at high risk for an early mortality. So I guess the one other thing that I want to say is that accessing trusted supports is such a key thing, and I understand that for many very clear reasons, it's hard to find. It can be hard for our community, communities of color to find support within the medical system, within the mental health system. And I think it's so important that people got to see your face and connect with you, all of you, to connect with you, because you look like them. I don't, and most people out there don't. And it's, you and I all know people who, in a certain respect, aren't going to be able to afford to wait for the system to look more like the diversity that is our broader community. So any way that anyone can play a role in helping somebody know that their life matters to somebody or to God or whoever, whatever resource is important, and to help somebody find their way. It's so hard to do this in isolation.
Wow, so you can see how each one of them are vastly different. So we were talking about what we know around health disparities. We know we don't want to go to the doctor stories because of, I'm scared, I don't trust the right person, they don't know who I am, they can't relate to my life in the hood because they're privileged. We know all those stories, but we want to also look at some things around genetics, possible diet, relationship, things that bring about that. So can we do a quicker roundabout? We have a time check of about 30 minutes, and we'll do some Q&A and interactive because we don't want to lose our wonderful guests. So, Shai, I remember you telling me a story, and I wish you could share it with us.
I have an aunt that was born with syphilis. The syphilis was transferred from my grandmother, and when she was pregnant. I didn't know that she had the disease. She went many years untreated, and because syphilis is a type of disease that the early symptoms you know when you have it. Basically, when you are an adult, you have some type of infection, shows signs of infection, a sore that heals and goes away. It stays latent and dormant for years, untreated. And what happens then is that it starts to travel around the system. And in a later age, it becomes hitting your brain. And they call it neurosyphilis. So at that point in time, you become demented. So a lot of African Americans, a lot of seniors, they don't even know that this could be the cause, and the family members might not even know, because they went so long without it being treated and knowing that they had it. Because the majority of times, if a woman is married and they only have sex with their husband, they're not even expecting to have the disease. So a person who's born with it may not even know they have it. Now, most of the times when the child is born, depending on what hospital you were in, what city you were in, they usually test the child. But in the southern states, they did not. So a lot of children were walking around with syphilis or gonorrhea. And my aunt ended up being demented. And not until she got up in age that someone actually decided to test her for that. And only because they did all the other tests like HIV, lupus, they were doing rheumatoid arthritis, because anything that was immune depressive, they were trying to figure out why she would have it. But no one thought about the syphilis until the last of all the tests. And by that time, now she was demented. They automatically put you on antibiotics, but by that time, the antibiotics cannot prevent what already has occurred. So if you became blind, if you got weak, if you've lost some of your memory, if you got unsteady gait from all that neurosyphilis, none of that can be corrected. So I'm just saying this because of the fact that I have a personal person that I was very close to, but that I see this type of syphilis going untreated in many of our people, African Americans, because we don't want to come to the doctor, especially LGBT. We don't want to tell them that we might have multiple partners, or we might not want to tell them that we were homeless, that we were on drugs and, was selling our bodies, for the drugs, or had multiple relationships. And so it's hard. You don't want to go to the doctor and say, I'm not heterosexual, I'm homosexual, So look for something else. Look for another way, because, hey, I'm afraid to tell you. So I may not come back. I may let you do a test, and it's a simple blood test, and that's the whole point. And if you don't ask the doctor for that particular blood test, it's not a standard test. You can go for your physical every year, and the doctors would do a CBC, they would do chemistries, they would do everything else, but they may not do that unless you ask for it. And the same thing you sign for, a doctor may say, let me do the test of HIV, but you have to sign for it, okay? Some people don't want to sign for it. Some people don't want to go through all that. Some people are afraid to do that. Some people are afraid to know. So the syphilis itself is just a simple test. You don't have to sign for it. But it's walking around here in many people and latent. And like I said with my aunt, it may not be found until later in life. By that time, it's going to hit your bones. It'll hit many other areas. And thank God my family is very close to my aunt, so her children are taking well care of her, but this is something that was personal for me.
Wow, thank you. That enlightened me, because who thought, or as we say, who would have thunk it in New York? Yeah, and Nina, in your practice around spirituality, which I adore because I follow it too, it motivates, you to do better. But we were talking the other day about diet and intake and how it's associated with certain behaviors around mental illness. So can we? Yeah. We were talking about, that sugar that people eat, sometimes living in certain environments, all that food that make you a little hyper, or people that may be hypoglycemic and don't know, and then they eat 3-4 times the sugar that they can't process, and how that might cause the behavioral issues.
Okay, I hear that, but how do we stop people from doing that is the piece. The work that I do, I call soul therapy, because many people are just like pushing back on psychotherapy, because no, I'm no psycho, I'm not that ill. So I try to talk with them and, look at the whole person. Look at their diet, of course, whether or not they're involved in any exercise, whether they can use more perhaps cultural friendly modes of healing, like herbology or aromatherapy, some homeopathy, trying to move away from destructive behaviors. But in our own way, we try to do ourselves in because of our own lack of love, So my work entails helping people to love themselves, because that's where the healing begins. And love, as we know, is a very powerful healing tool, love and laughter. So those things are things that I bring into my work. And, in talking with people and truly being there for them, we can help to turn them away from destructive patterns, but they have to do it. So we can do that in support, just by being there, again, with the power of our presence, presenting alternatives and assisting them in doing better.
Right.
Can I add something?
Yeah, sure. You're up next, too, so.
So I just wanted to add to what Nina was saying, and it's really about helping people to understand that what they're going through is something that it could be generational. One of the things that I enjoy doing is just doing a genogram with my clients when they come in, because in every generation, there's a pattern there. And once you can help them identify what the pattern is, the issue is still there, but it may not be as daunting as what they thought. Sometimes it could just be, there is a family member who has been isolated, who has behaved a similar way, but you can see that there was a pattern. That could be generational, and once they can identify it, your goal is to help them figure out what the problem is, and then help them figure out how they can resolve it for themselves. You're not doing it for them, but to help them chart a course that's going to make it a little different for them.
Right. And can you give us some information about your specific work around LGBT clients?
So one thing is the generational, just really looking at the history and their family traits and behaviors and any emotional issues, but also one of my specialties is really grief therapy, and really looking at grief and health and how grief impacts your health. Just my personal experience is that, I started a lesbian widows group because it didn't exist. And not that a bereavement group with many people having different losses wasn't good, it wasn't enough. And so I was able to, start a lesbian widows group to talk about females who have lost their life partners. This is all obviously before marriage equality, where we were losing our homes, where we were losing our finances, whatever it is that we had in our couple situation was lost. My partner passed away 8 years ago now, from breast cancer. And so while I did go to grief counseling, again, it was good to hear other things, and I learned a lot from it, but it just wasn't enough. And the other thing is she had great health insurance, so that wasn't the issue. The issue was just getting people to make sure that she was getting the services that she needed when she needed it. Sitting in waiting rooms, waiting for endless hours, sometimes machines breaking down, which I didn't understand why a machine would break down in the health field, but it did. It does. I know it does. But again, being demanding about it, it's like she can't sit here and wait, and being able, as a mental health professional, you forget that you still need to advocate for yourself. And I think, that gets lost. We can always advocate for other people, but sometimes it's hard to advocate. So those were one of the things that I learned, to advocate for her, for me, to develop something that was needed out there. And I always believe that if something doesn't exist, make it happen, create it.
Well, as you can see, why we work with these distinguished women, because the Circle of Voices, we have unusual circumstances, and I stand before you as a cancer survivor, and I can walk through the mantra, early detection saved my life, and as a woman of color, of African descent, culturally, your hair is your crown. That might have been the one possession that you could have that massa didn't take from you. So, and you couldn't afford a hat. You know, we was poor. And so, in going through my diagnosis, one of the doctors was like, little chemo, a couple of rounds, you lose your hair to grow right back. You know, I lost it. They had to call security. Because I said, you don't know. I'd rather die than be bald. That's how important hair is to me. In certain cultures, you have to respect that. And that's how Lesbian Cancer Initiative came to my life. I fought until I said, I want this job. I didn't go there for the job. I'm here to work. She'll tell you. Because of some of the things that happened to me. And automatically given a diagnosis of cancer, you have to go to see a therapist. I'm like, ain't nothing wrong with me. I got cancer. I could beat this. I caught it early. The woman that I went to, Butch, Hispanic, said to me in 5 minutes of knowing me, if you say anything that might question your safety, I will have to have you admitted. I said, I ain't trying to jump out no window. Are you crazy? I went downstairs and got her fired. I was relentless. I called every board there was. I said, this woman cannot practice in this state. I'm sure you will find more evidence of this behavior because this is ridiculous. Even if I was dying, let me enjoy the days that I was having. So this is another reason why we do the work that we do. I have women calling us. I had one yesterday. I heard you can help me get health insurance. Because with health insurance, you can start somewhere. At least you can ask. Women have come to me and said, I can't find a social worker. Lori's practices in Long Island. Everyone we sent praised going to Long Island from Brooklyn. They are looking forward to going to Long Island. You know, I'm not. I drive. But I'm saying it's so important to find the right counselor, the right person to take care of you. And I hold all of you guys that practice responsible. If it's not a good fit, do not recommend it to, a client, another colleague, if you cannot save this person's life. So I want to introduce one thing and then we'll do Q&A. I had the distinct pleasure of working with a women of color organization called Zuna Institute. Anybody ever heard of Zuna Institute? They're out of Sacramento, California. Right, Francine Ramsey is the ED, and this is what's in front of you, Black Lesbians Matter. This was in 2010, so they knew before all this other, the Black Lives, they knew. Right, so I had the pleasure of being one of the distributors and actually going to be as a presenter at the Creating Change Minneapolis, where we presented this wonderful qualified data, and I brought it in because if you guys need to have data that is qualified and quantified by professionals like Dr. Juan Battle and Dr. Nita Mosby out of Colorado, this is it. And they looked at every aspect of Black lesbians' lives. And the idea was behind it, a lot of people don't know their worth. They don't know their value, especially people of African descent in this country. So they looked at every detail from mental health to economy to abuse, marriage, education. And the big thing was Black lesbians like being educated. That was like, woohoo! But we talked about mental health, which is on page 9. So let's go there. Because it's just so much and we only have an hour and 15 minutes. So, okay, I think I found it. Come on. You can't see on the computer. Come on, come on, come on. Okay, here we are. Each page they took a note from a survey respondee, and the woman said, I would also like to mention an issue that might come under mental health. Internalized homophobia. If a person thinks they're less than, that they're going to hell or whatever, they don't have it within themselves to really join a community and try to get something achieved. So in this portion, which is true, we hear that a lot. So that's why a lot of lesbians are isolated by themselves because they don't feel good. But in this, they talked about the negative things that happen to black women. They talked about us being a riskier health group because of our risky behaviors compared to our white counterparts. They talk about the disparities of women not following up, the uninsured aspect, because in the assessment, 16.9 of the respondees were uninsured compared to 24% of black women nationwide. So that was like, wow, that's a biggie. So we also found out that it wasn't necessarily based on income. There were still some women who made money, but did non-traditional work that didn't offer them insurance opportunities. So there's a whole broad aspect of disparities around people of color and women of color not seeking mental health and regular medical health. And another issue came up that people of color communities, when I spoke to all of them, they kind of agreed that in people of color culture, we don't see mental illness. You know, we all have a cousin that may be an alcoholic or auntie that's always, as we say, cutting a fool. But that might be the mental illness or that pattern that Lori spoke of. So we have to start looking at that pattern within our own families and trying to do something around that. And there was a story that was shared by our executive director about how family patterns impact you. There was a family that always had an annual Thanksgiving family reunion kind of thing. And every year they would have a ham. But this particular ham with this family, they always cut off the two ends. So a new member in the family said, well, why do y'all cut off the two ends? Well, they said, well, great-grandma always did it this way. And the story was she was poor. So the pan she had, she couldn't fit the ham, so she just cut the ends off. And these people kept doing it for generations and generations. So that, again, confirms how something that might be minute can also be very huge. So I'd like to take some questions from you. Anybody have any questions for the panel? And thank you, Antoine. Okay.
So I am a first year MBA student, and I'm very much interested in spreading awareness of mental health within the minority community. So from your practices, how can we engage people to talk about their mental health, mental illnesses?
As a student in classes, or
No, in general, because eventually when I graduate, I would love to work within the community, like hopefully through like health promotional programs, health implementation or policy or whatever that might be. So as a student who is currently studying, like what are some things you are really looking at or trying to research that would help in one way?
culturally, we don't like to talk about it. That's very difficult because I believe most of us can remember grandma, granddad, uncle, brother, older brother, somebody always acting different. I had a father that had paranoid schizophrenia. And when I was growing up, no one knew that. He didn't know it. So how different he performed to his behavior was that every time my mother's family would come, and my mother's side had a large family, he would just go in the room. So he didn't socialize with us. We had no way of knowing that this man had paranoid. We just took it for his norm. When the big family came, he left us alone. He didn't come out. He would say hi and just escape, okay? As he got older, and got in his 60s, the paranoia got really bad. He got to a point where he was blocking the doors, closing up the windows, not letting anyone come in or out of the house. And eventually, I had to take him to the hospital. By that time, I was an adult. And come to find out that his paranoid schizophrenia had been caused more than likely by a military time. My father was a prisoner of war. And he was stationed in Paris. They locked him up in a cell that was in complete darkness for 2 years. Okay? So these are the things that I didn't know about. And my family didn't talk about mental illness, very rarely. The neighbors didn't talk about it. You knew somebody had a problem down the hall. Maybe they was yelling and screaming in the middle of the night, running up and down the halls. But hey, we didn't know that was mental illness. So I took my father, started getting treatment, and then by him talking and telling the doctor about all of this, then I turned around and said, Dad, why you never told us this? Okay? He never told us any of that. This is something he locked away in his head. He didn't want to talk about, and now it came out. And it was slowly coming out as a young man. But not until he got in his 60s did it actually become full-blown. It just, the way it was. So he had to be admitted. He had to go on psychotropic drugs. And he spent his whole life, from the 60s till he died at 85, of being in and out of the hospital, trying to be treated in a VA hospital.
In response to this question, do you feel that we should engage our family members more?
Yes, definitely. I think we should ask to take the person to someone who can offer professional help. That would be a great answer. Oh, you got these behaviors, let's go somewhere. Let's go find out what's wrong. Is it a medical problem? Is it a physical problem? Is it just a mental problem or what? Because we don't know. But the only way to know is to go to a professional and go to a medical professional and find out. And to me, yes.
I think it's also the sharing of stories. We can sit around the kitchen table and we can get all those family recipes, and we have that, but we're not asking about great grandma or uncle, whoever. There's those histories as well too. There's that information, and if you're listening, you're going to hear the family traits that are going on. You're going to see. They're going to tell you exactly who has done what. They may not be clear on why, but you'll piece it together. And I think if we have more conversation about our families with the elders in our families while we can, the information is there.
Okay, I saw a hand. Yeah, 10 minutes.
Yeah, because he just touched on something that made you folks go into a really valuable piece, which is trauma. So, when it comes to working with minority women, I'm a Latina, that have experienced trauma, how do you, each one of you, see that can cause maybe not so much a barrier, but maybe you have to address it in a different way? So, for you, that you use the spiritual aspect of it, and then what you were saying about your dad, also the trauma. So I just kind of want to hear, how do you handle or deal with the trauma to create that environment for healing?
For me, it's in different ways, because it's the adults and then it's the children in foster care. So just their removal from their parents is causing trauma. And so we try to, with children, we're dealing with that behaviorally, and we're trying to look at what they're doing. I'm not a big component of medication for children all the time unless it's absolutely necessary. I find in foster care, if there's a behavioral issue, they're quick to give them, something for ADHD. They want to give them medication to calm them down, as opposed to really, really looking at why I'm acting out. Sometimes it's not being heard, and someone placing them with the right foster parent that's going to take the time to hear and to look at those behaviors, and with the caseworker or whoever it is, try and figure out what else can be done differently. It's also working with the parents. In adults, if it's sexual abuse, it's talk. For me, it's really helping them to talk it out. If it goes beyond that and medication is necessary, then that's a different aspect. But I really think if you can make a comfortable, safe environment. Safety is the key to people being able to talk about their issues and their concerns, whether that's in a large room, a big room, whatever it is that you have to make them feel safe enough and secure enough to start talking about trauma, and then you begin to deal with it that way. That's just the beginning of it.
I saw a hand up.
Just wanted to address it. One more. In terms of addressing the trauma, sometimes through writing. Writing is a very powerful healing tool. And also meditation. You know, seeing yourself heal, being able to take yourself into the situation and actually ordering a different way for yourself, and prayer. Prayer always helps.
Okay.
So I am a mental health consumer, not with women per se. Do you feel the services now are better, like opposed to 10 years ago or 5 years ago? I mean, there's a lot out there. There's DBSA, Depression Bipolar Support Alliance. There's NAMI, National Association of Mental Ill. They have a whole multicultural action committee page for nutrition. I mean, there's a lot. I know this because I talk about this, and I think the issue on empowerment. Do you find some of the women that you help, the fact that they've gone through all these extra steps like yourself, and you know to go downstairs and you know to advocate for someone? It's almost like an ombudsman. That through this, are you finding that some of these other women are now becoming more advocate, opposed to so there's things like that. NAMI has a thing called In Your Own Voice where it talks about that. All these organizations have chapters all over different cities within different states. They're called affiliates, and they offer free trainings. Free trainings on becoming a certified peer specialist, which you're not certified, but it empowers you to then take it out into the community. So I want to make sure you know those resources are available. Things around food. I'm not absolutely correct, but if you have a poor diet and you're on disability, you can go to your doctor and get a letter saying that you have dietary needs, and that requires you that gets you extra money in food stamps.
Sometimes. Not all the time.
So I think the services are getting better.
No. Yeah, the service is getting better, but that particular area is not. Because the doctors have written many letters for many of my patients, and the insurance has still said no. Okay, so insurance depends on what type of insurance you have, and you can get the food stamps without insurance. You can definitely.
And the last component of it is at these places you work, it's HIV, it's mental health, correct?
Yes.
Do you find between the two, within the one agency, I find that integrated healthcare is a big issue. That within the one building, so if you're in HIV and you're in a waiting room, you see flyers about HIV. You do not see flyers about mental health. So therefore, if you're sitting in a waiting room and you're looking around, where's questions about mental health? And so some person goes in and they're talking to their provider. They don't know to ask the question. I've been depressed for 6 weeks. I don't feel really well. And then the last touch is, and when you're out there in your offices, do you put up a rainbow flag? Do you put up a pink triangle? Why? Because your client walks in there, they identify that, they feel comfortable. Opposed to if that stuff's not available. That's just some suggestions.
I agree that the services have increased and they're getting better. The concern are the people who are not ready to go for those services. Sure. They are the ones that are in the room that you're talking to and that you're trying to build their self-esteem to go to the next step. So I go back to making a safe environment, starting there and then. I had a client I was working with the other day, and she will talk to me. I finally got her to be able to go to a grief group, and she started going. But initially, that wasn't even on her, that wasn't a thought in her head.
Okay, we got about 5 minutes and 2 questions. I'm going to ask when we both make them tight. Sir, I believe you were next, and then Ms. Lee.
I just make my comment. I really appreciate your approach to addressing mental health and mental illness. Because I compare it to sort of Eastern medicine and Western medicine. Western medicine is my hand hurts, I put ice on your hand. And Eastern medicine is your hand hurts, then your wrist hurts, and your shoulder hurts. And your approach is really about sort of following meridians. If there's an issue here, it's somewhere else with the base being spiritual. I really appreciate it. I think it's important to get that out and have people start to look at mental health and all kinds of health and realizing how they all interact, and at the end, what's the root problem. So I just want to acknowledge that.
Thank you.
I work in HIV field. I work and so, we don't see much HIV or
LGBT.
But I'm working on creating a more friendly environment for everybody in minority. So how do we bring, mental health is a big issue, access is a big issue, and the quality of service. We probably talked about the quality of services. We talked about some wonderful work that some people do, sometimes in isolation. So how can we bring some of these good initiatives to community places that to expose people that we work with? I mean, not just the participants, but also start with the staff. The staff can be a little bit more conscious about how to integrate all of this. We have great opportunities in work when we have a social services agency, whether the focus is also here, HIV or whatever. You have people that are coming there every single day.
Right.
That you can start, exposing to all this, wonderful work to prepare them for that step of, okay, I'm gonna find a psychotherapist, whatever form of, mental health healing will work for you, but until people are more exposed, as the gentleman was saying, they're not going to go that route.
Well, I'll be happy to follow up with you and give you some referrals of agencies and experts, and maybe management will open up, or if they need a presentation from Circle of Voices, we'll be glad to. So please find me and let's follow up, make sure I have your information on that sheet. Okay, so we're about to wrap up. It's 2 minutes. If you need to find us, Circle of Voices is a public charity, so we are accessible by 411, y'all still use it, or Google. I have to respect both genres. www.circleofvoicesinc.org. We do a lot of work in the community. We have a member of the upcoming Black Lesbian Conference that's coming up here in New York, Elise. So she has information coming up March 25th, 26th of 2016 at Barnard. So that's some of the things that we try to help and bring forward and support to make sure that there is a safe space for women of color and women of African descent, LGBTQ, cisgender.
Trans and cisgender.
Right. Yeah, I'm learning too.
Yeah, me too. Trans and cisgender, transgender and cisgender, Black, African descent, lesbians. And thank you, Kaz, for mentioning that. If I have some cards here that defines who we believe, who believe all that encompasses of trans, cisgender, Black, African descent, lesbians. So if you're interested, I got some.
Right. So on that note, I invite you to visit, like us on Facebook, Twitter, and if you need some help, we're here. And I'd like to thank my distinguished colleagues, friends for being here and letting me know the uniqueness of their work with the disparities that we face. So again, let's round of applause for our distinguished panel. Kaz Mitchell, Hannibal, and Christina Modell. And I'm Kaz Mitchell. Thank you so much.